The topic of today's discussion is on intraoral radiographic techniques. As in the previous session, we have discussed about the different intraoral techniques like the paralleling and bisecting angles. Today, we will be discussing to deal with different angulations and different projections used for each techniques. Intraoral radiographic examinations are the backbone of imaging for general dentist. A full mouth set of radiographs will consist of periapical bite wing projections. These projections, when well exposed and properly processed, can provide considerable diagnostic information to complete the clinical examination without the need for further advanced radiographic projections to be advised. So, the topic will be dealt under the following contents today. Firstly, we'll see general steps for making a radiograph, whether it is periapical imaging, occlusal, or the bite wing. Then we'll see imaging of the children and mobile imaging. Then we'll go to see the special considerations for individuals who are having infections, trauma, and individuals with mental and physical disabilities, people with excessive gag reflex, imaging for endodontics, pregnancy, and edentulous patients. Firstly, we'll see the general steps for making an X-ray image. We have to prepare the patient first before the exposure. So, place the barriers for universal infection control and have receptors and receptor holding instruments ready at the chair side. Then greet and seat the patient. Position the patient upright in the chair with the back and the head well supported and briefly describing the procedure what we are going to perform. Position the dental chair low for maxillary projections and elevated for mandibular projections. Ask the patient to remove eyeglasses or any other metallic instruments or the accessories what they are wearing. Drape the patient with the lead aprons and regardless of whether it is a single exposure or a series of full mouth exposure. If it is seeming necessary to apologize for any discomfort caused during the procedure, ask sorry after the examination or the procedure. Next is adjusting the X-ray unit setting. Set the X-ray machine for proper KVP, MA and exposure time generally. Only the exposure time is adjusted for various anatomic locations. And now we have to thoroughly wash our hands in front of the patient, or at least the area where the patient can see us washing, or observe the washing of hands and put off your disposable gloves. After this, examine the oral cavity. Before placing any receptors in the mouth, examine the teeth to estimate their axial inclination, which influences the placement of the receptor. Also note for any other abnormalities like tori or obstructions to modify the receptor placement. Then position the tube head. Bring the tube head to the side to be examined so that it is readily available for final positioning after the receptor has been placed in the mouth. And also, next step is positioning the receptor. Insert the receptor into the holding device and position the receptor and holding device in the region of interest in the patient's mouth to be examined. Leading with the apical end of the receptor, rotate and place the receptor in the oral cavity as far as possibly from the teeth. This will provide the maximum space available for the midline with the shallow palates and greatest depth towards the central or floor of the mouth. Also, we can place cotton roll between the bite block and the teeth opposite those being radiographed. This will help stabilize the receptor holding instrument and in many cases contributes to patient's comfort. Next is positioning the X-ray tube. Adjust the vertical and horizontal angulations of the tube head to correspond to the receptor holding instrument. The end of the aiming cylinder of the X-ray machine must flush or be parallel to the guiding ring or the instrument. Aligning this is very important. Caution, ask the patient not to move. Lastly, make the exposure. Make the exposure with the preset exposure time. If the receptor is film or a storage PSP or CCD, then after exposure, remove the receptor from the patient's mouth, dry it with the paper towel, place it in an appropriate receptacle outside the exposure area. If it is any CMO's sensor, then you may be able to keep it in the patient's mouth and repeat or reposition it for the next use. With this, we come to an end on the steps or the general steps for making a radiograph. Now we will see the full mouth set of film or the radiograph consists of what all? That is 17 periapical views and 4 bite wing views as shown in the given picture below. Now, as these projections or the radiographs are projected, we will be seeing the techniques and angulations for each one of them. Firstly, we will discuss on the maxillary central incisor projection. Direct the central ray through the contact point of the central incisors and perpendicular to the plane of the receptors and roots of the teeth. Because the axial inclination of the maxillary incisors is about 15 to 20 degrees, the vertical angulation of the tube should also be with the same positive angulation. But the horizontal angulation should be 0. Point of entry. Direct the point of entry of the central ray high on the lip in the midline just below the septum of the nostril. Next projection is maxillary lateral projections. Direct the central ray through the midline of the lateral incisor with no overlapping of the margins of the crowns at the interproximal space on its mesial aspect. And also make sure that you do not attempt to visualize the distal contact with the canine. Point of entry. The central ray will be oriented high on the lip 1 cm above from the midline. Next is our maxillary canine projection. Position the holding instrument so that it directs the beam through the mesial contact of the canine, not the distal contact. Point of entry. Direct the central ray through the canine eminence. The point of entry extraorally will be about the intersection of the distal and inferior borders of ala of the nose as shown in the given figure. Next is your maxillary premolar projections. Direct the central ray perpendicular to the receptor. Horizontal angulation of the holding instrument should be adjusted to permit the beam to pass through the interproximal area between the first and the second premolars, as shown in the picture on your dried skull. Point of entry. Place the holding instrument so that central ray passes through the center of the second premolar root. This point usually is below the pupil of the eye when you look into extraorally for the aiming device on the patient's face. Our next projection is maxillary molar projection. Direct the central ray perpendicular to the receptor. Adjust the horizontal angulation of the receptor holding instrument to direct the beam at right angles to the buccal surfaces of the molar teeth. I am repeating, we should direct the beam at right angles to the buccal surfaces of the molar teeth. Point of entry, where the central ray should be on the cheek below the outer canthus of the eye and zygoma at the position of maxillary second molar. Now we'll move to the mandibular projections. Firstly, we'll be discussing on the centrolateral projections because central and the lateral incisors in the mandible have the same anatomy. Direct the central ray from the posterior aspect through the third molar region. Orient the central ray through the interproximal space between the central and the lateral incisors. The point of entry would be such that the central ray will be entering below the lower lip and 1 centimeter lateral to the midline. Next projection is the mandibular canine projection. Direct the central ray through the mesial contact of the canine without regard to the distal contact because of the curvature of the mandible here. Point of entry is nearly perpendicular to the allow of the nose over the position of the canine, about 3 cm above the inferior border of the mandible. Our next projection is mandibular premolar projection. Position the receptor holding instrument to project the central ray through the second premolar molar area. Vertical angulation should be small, nearly parallel with the occlusal plane to keep the receptor as nearly parallel with the long axis of the teeth as possible. Adjust the horizontal angulation and the placement of the receptor holding device to direct the beam through the premolar contact points as shown in the dried mandibular skull in the figure. Point of entry of the central ray is below the pupil of the eye, about 3 cm above the inferior border of the mandible. Next is mandibular molar projection. Proper placement of the holding instrument directs the central ray through the second molar. Adjust the horizontal angulation to project the beam through the contact areas. Because of the slight lingual inclination of the molars, the central ray may have a slight positive angulation, say appropriately about 8 degrees. Directing the point of entry of the central ray below the outer canthus of the eye, about 3 cm above the inferior border of the mandible. Now we will move to see the bite wing projection techniques. Firstly, what we will see is premolar bite wing projections. Adjust the horizontal angulation of the cone to project the central ray to the center of the receptor through the premolar contact areas. To compensate for the slight inclination of the receptor against the palatal mucosa, vertical angulation should be given, which is about 5 degrees, that is positive 5 degrees. Point of entry, we have to identify the point of entry by retracting the cheek and determining that central ray will enter the line of occlusion at the point of contact between the second premolar and the first molar. Next is our molar bite wing projection. Project the central ray to the center of the receptor and through the contact of the first and the second maxillary molars as shown in the given figure. Angle the central ray slightly from the anterior because the molar contacts usually are not oriented at right angles to the buccal surfaces of these teeth. A vertical angulation of plus 10 degrees is considered or recommended. Point of entry, the central ray should enter the cheek below the lateral canthus of the eye at the level of occlusal plane. With this, we will move next to looking into the occlusal projection, where firstly we will discuss anterior maxillary occlusal projection. Adjust the patient's head so that the sagittal plane is perpendicular and the occlusal plane is horizontal to the floor. Now place the receptor in the mouth with the exposure side towards the maxilla, the posterior border touching the rami of the mandible and the long dimension of the receptor perpendicular to the sagittal plane. Ask the patient to stabilize the receptor by gently closing the mouth or gently biting with the thumb pressure. Projection of the central ray should be such that the central ray should pass through the tip of the nose towards the middle of the receptor with approximately plus 45 degrees vertical angulation and 0 horizontal angulation. Point of entry, the central ray enters the patient's face approximately through the tip of the nose. Next is topographic maxillary occlusal projection. Seat the patient upright with the sagittal plane perpendicular to the floor and occlusal plane horizontal. Place the receptor with its long dimension perpendicular to sagittal plane. Gently push the receptor in the backward until it contacts the anterior border of the mandibular rami and ask the patient to stabilize it. Direct the central ray at a vertical angulation of plus 65 degrees and horizontal being 0 degrees to the bridge of the nose just below the nasion towards the middle of the receptor. Point of entry: generally the central ray enters the patient's face through the bridge of the nose. Next is lateral maxillary occlusal projection. Place the receptor with its long axis parallel to the sagittal plane and on the side of interest with the tube side towards the side of the maxilla in question. Push the receptor posteriorly until it touches the rami. Position the lateral border parallel with the buccal surfaces of posterior teeth, extending laterally approximately 1 cm past the buccal cusps. Ask the patient to close gently or stabilize the receptor. Orient the central ray with a vertical angulation of plus 60 degrees to a point 2 cm below the lateral canthus of the eye, directed towards the center of the receptor. The point of entry being where the central ray will enter at a point approximately 2 cm below the lateral canthus of the eye. Next is anterior mandibular occlusal projection. Seat the patient until the patient's head is tilted back so that the occlusal plane is 45 degrees above the horizontal, because now we are focusing on the mandibular occlusal projections. Place the receptor in the mouth with the long axis perpendicular to the sagittal plane and push it posteriorly until it touches the rami. Center the receptor with the pebble side down and ask the patient to bite lightly until he holds the receptor in position. Orient the central ray with minus 10 degrees angulation through the point of the chin towards the midline of the receptor. This gives, say, about minus 55 degrees of the angulation to the plane of the receptor, similar to that of the bisecting angle technique projections for the lower incisors. Point of entry of the central ray is in the midline through the tip of the chin. Next is topographical mandibular occlusal projection. Seat the patient in semi-reclining position with the head tilted back so that the ala tragal line is almost perpendicular to the floor. Place the receptor in the mouth with its long axis perpendicular to sagittal plane and with the tube side towards the mandible. The anterior border of the receptor should be approximately 1 cm beyond the mandibular central incisors. Ask the patient to now gently stabilize the receptor. Direct the central ray at the midline through the floor of the mouth approximately 3 cm below the chin at right angles to the center of the receptor. Point of entry of the central ray is in the midline through the floor of the mouth approximately 3 cm below the chin. Now, next we will discuss the lateral mandibular occlusal projection. The projection covers the soft tissue of half of the floor of the mouth, the buccal and the lingual cortical plates of the half of the mandible. Seat the patient in a semi-reclining position with the head tilted back so that the ala tragal line is almost perpendicular to the floor. Place the receptor in the mouth with its long axis initially parallel with the sagittal plane and with the pebbled side down towards the midline or in the mandible. Place the receptor as posteriorly as possible. Then shift the long axis buccally, either right or left depending on the site of your interest, so that the lateral border of the receptor is parallel with the buccal surfaces of the posterior teeth and extending laterally approximately 1 cm. Direct the central ray perpendicular to the center of the receptor through the point beneath the chin, say about approximately 3 cm posterior to the point of chin and 3 cm lateral to the midline. The point of entry of the central ray is beneath the chin, approximately again 3 cm posterior to the chin and 3 cm lateral to the midline. With this, we come to an end on the discussions of different techniques and angulations or projections used for periapical, bite wing and the occlusal radiographs. We will see a new concept. It is called as mobile imaging. There are occasions when it is difficult to have a patient to come to a conventional wall-mounted dental X-ray machine himself. For instance, in remote sites such as nursing homes, hospitals or disaster scenes, it could be highly advantageous to have a portable machine that could be taken directly to the patient. Combining such a portable X-ray machine generator with digital imaging provides rapid, self-contained imaging capability. In recent years, such a portable battery-powered X-ray generator has been approved by the Food and Drug Administrations. Clinical trials have shown that this unit can be held stable and produces clinically acceptable images. The machine uses, say, about 60 kilowatt constant potential and has got a short focal spot skin distance about 20 centimeter. Both these factors allow for a short exposure time compared with the conventional units. It has a small focal spot of about 0.4 millimeters. The operator dose is mitigated by the use of internal shielding materials in the unit to reduce the exposure leakage. And also, aiming cylinder is shielded to minimize the backscatter of the patient as shown in the figure, which is a orange transparent sheet. These units are approved for use in many but small or not in all states except in US. So, with this we come to an end on the discussion of first part of the intraoral radiographic techniques and examination. In the next session, we will be dealing with the other half of the discussions like child imaging and special considerations. Thank you.